The information on this DVD is presented to you by AMI, Agency for Medical Innovations. Around 50% of the world's population suffer from hemorrhoids at some point in their life. Approximately 10% of those affected will end up undergoing surgery to cure them. In 1995, a new method of treating hemorrhoids was described for the first time by Dr. Morinaga et al. From Japan in the American Journal of Gastroenterology. Today, this method of hemorrhoidal artery ligation is commonly known as HAL. AMI then made further advancements to the technology and has been offering the method to surgeons for some 10 years since. Hemorrhoids are arteriovenous cushions which serve to maintain the fine continence of the anus. Recently, novel and interesting discoveries have been made concerning the vessels supplying blood to these cushions. The traditional theory that hemorrhoidal arteries are located in set positions, for example at 3, 7, and 11 o'clock, has now been disproved by new studies showing that the course of these arteries is much more random. During the last few years, the rectal arteries have been the subject of considerable scientific attention. A study published in 2008 showed that the superior rectal artery is in fact the only artery of any significance supplying the hemorrhoidal cushions. Here it can also be seen that the number of smaller arterial branches in the corpus cavernosum recti differ greatly from patient to patient. The same also goes for the position of the rectal arteries in the hemorrhoidal cushions. In summary, it can be said that neither the number nor the position of the rectal arteries is predictable. This fact plays an important role in explaining the success of the HAL method. A study investigating the diameter of the large rectal arteries as well as the blood flow also reveals a second important factor. The results of this study show that in patients with hemorrhoidal disease, these arteries are almost twice as large in diameter, with a blood flow 3 times greater than in healthy patients. This leads us to conclude that the increased arterial supply is responsible for the development of abnormally large hemorrhoids. Differentiating between the different grades of hemorrhoidal disease is important for determining the most suitable treatment. According to the Gallagher classification, there are 4 different grades. However, for the purposes of this DVD, we simply refer to the low and high grades of hemorrhoids. Low corresponds to grade 1 and grade 2 of the Gallagher classification, those stages of the disease where the hemorrhoidal cushions generally remain inside the anal canal. High grades of hemorrhoids, that is, grade 3 and 4, are characterized by hemorrhoidal tissue prolapsing out of the anal canal, whereby grade 3 hemorrhoids can still be pushed back into position. The method of treatment for hemorrhoidal disease varies according to the stage of suffering. Lower grades of hemorrhoids are treated by such procedures as rubber band ligation, sclerotherapy, and cryotherapy. These are all outpatient procedures. However, they generally have quite high recurrence rates in comparison, and often result in further treatment being necessary. Higher grades of hemorrhoidal disease are treated surgically, for the most part with conventional hemorrhoidectomy and in some cases with the stapling method. The considerable pain often experienced by patients after undergoing a conventional hemorrhoidectomy, and the severe post-operative complications occurring in some instances after stapling, resulted in the search for a method of treatment low both on pain and complications. The HAL and RAR methods are minimally invasive procedures and have the advantage that they can be used for all stages of hemorrhoidal disease. HAL is used for lower grades of hemorrhoids, while RAR is effective for the higher grades. Both procedures are virtually painless for the patient, and up until now, not one single severe complication has been reported in literature, despite the method having been used to treat several thousands of patients worldwide each year. The HAL method is used to treat low to medium grade hemorrhoids. The AMI HAL Doppler system allows the hemorrhoidal arteries to be located precisely in each individual patient. Special Doppler ultrasound equipment is used for this purpose. The handle is equipped with 3 high-performance LEDs which ensure the light is sufficiently bright at all times to allow the surgeon the best possible vision. A probe containing an integrated ultrasound sensor is attached to the handle. This sensor can also receive the Doppler signal, as well as measure the depth of the arteries. An outer sleeve is placed over the probe. The procedure is very simple. The surgeon works in the area contained by the ligation window. After inserting the Doppler probe all the way into the rectum, the surgeon starts to look for arteries at a depth of 4 to 6 centimeters. Here, careful attention is required. The handle with the probe attached is turned slowly until the first artery is detected and then held in this position. The depth of the artery can now be seen on the display. The strength of the Doppler signal indicates the center of the artery. Ligation can be carried out safely up to a depth of 8 millimeters. A 5/8 needle from AMI is placed into the needle holder and then inserted into the probe. The surgeon then ligates the respective artery through the ligation window into which the mucosa is falling. Due to the rectal blood vessels frequently changing their course, it is vital that the ligature be placed as close as possible to the Doppler ultrasound. If this is not the case, there's a high risk that the artery will be missed. A second stitch usually follows the first. Subsequently, the needle is cut off from the suture, and the two suture ends are knotted together. The result is a figure of 8 knot. Now the handle is turned slowly until the next artery is detected and ligated as before. This continues until one complete rotation has been made and all arteries ligated. In most cases, 5 to 7 arteries will be found. However, this can vary considerably from patient to patient and may also depend on the severity of the hemorrhoids. Subsequently, it is advisable to pull the handle back 1 to 1.5 centimeters and to make a second round of ligations on this plane. The result of these ligations is a reduced blood supply to the hemorrhoidal cushions, and hence a far better balance between the inflow and outflow of blood. In time, the hemorrhoidal cushions shrink and the success of the therapy is evident some 6 to 8 weeks after, when they are back to normal. Because the method is based on the principle of reducing the arterial blood supply, HAL is extremely effective in relieving the symptoms of hemorrhoidal disease caused by excessive pressure in the arteries. Bleeding, itching, and pain are treated with great success, regardless of what degree of hemorrhoids. The RAR method is used to treat higher grades of hemorrhoids involving a prolapse, which needs to be repositioned inside the anal canal. The term RAR stands for recto-anal repair, a combination of the HAL method as previously described, and one or more mucopexies of the prolapsing mucosa. Before executing the mucopexy, it is important to ensure that ligating of the arteries is carried out with similar care and diligence as for the HAL method alone. Only this way can we treat the symptoms of bleeding, itching, and pain successfully and achieve the same results as with HAL. Once all ligations are in place as for the HAL method, we can move on to the next step involving a running suture for each prolapse. Alternatively, the running suture can be placed immediately after the ligation using the same suture material. The mucopexy can also be performed with ease using the AMI HAL Doppler system. The AMI RAR flexi probes are made up of 2 components, an inner part that is connected firmly to the handle and an outer sleeve that can be rotated. The handle is moved to the starting position used for ligation. The ligation window and hence the handle point to the position requiring treatment. The RAR flexi probe must be inserted into the rectum in such a way that the prolapse can be lifted to maximum effect. As for HAL, AMI's 5/8 HAL needle is inserted into the initial stitch placed. If necessary, the mucosa can be pulled gently into the RAR probe after making the first stitch to allow more proximal placement of the second one. This results in a Z-shaped stitch. By successive turning of the handle, more and more mucosa becomes visible. Proceeding step by step is important to prevent all the mucosa falling into the probe's ligation window at once. Continuing in this fashion, the surgeon places a running suture which ends between 5 and 10 millimeters proximal of the dentate line, still in the pain-free area. The individual stitches of the running suture are placed some 7 to 10 millimeters apart, allowing room for 4 to 5 stitches in total. Once the last stitch has been placed above the dentate line, the needle is cut off and the upper end of the suture material by the initial stitch is then knotted to the distal end of the suture. This causes the prolapse to be pulled up in the direction of the initial stitch, where it is then secured in place with a sliding knot. The number of mucopexies differs from patient to patient, and the surgeon will decide how many are necessary as the operation proceeds. As a general rule, between 2 and 4 running sutures are required. However, it is certainly possible to perform more or even fewer. The RAR precision probe is the second type of RAR probe available. In contrast to the RAR flexi probe, the precision probe has a comb-shaped part designed to standardize the mucopexy. The first part of the operation, the ligation of the arteries, remains the same. To carry out the mucopexy, the outer sleeve is turned in such a way that the comb-shaped part of the probe is positioned directly underneath the sleeve's mucopexy window. Now the probe is inserted rectally, whereby the opening of the sleeve should be positioned where the first mucopexy will be performed. The teeth of the RAR precision probe's comb hold back most of the mucosa, leaving just the spaces between the teeth free to work on. As before, the running suture is now placed from proximal to distal, and care must be taken to place the last stitch far enough proximal of the dentate line so that no pain is experienced post-operatively by the patient. Once the last stitch has been placed, the handle is turned in a clockwise direction to release the suture. Now the prolapse can be lifted as previously described by pushing the sliding knot in the direction of the initial proximal stitch and then securing it. The mucopexy with the RAR precision probe can be carried out at several prolapse positions if necessary. Because the prolapsing hemorrhoidal cushions are secured in place in the rectum, the result of the prolapse treatment is usually visible immediately. The RAR method can thus be considered equally effective for treating the symptoms of hemorrhoids as well as the prolapse. The symptoms by means of the precise ligation and the prolapse by means of the mucopexy. In principle, surgical techniques should be effective, patient-friendly, or in other words, low pain, and result in as few complications as possible. To a great extent, these criteria are filled by the minimally invasive methods HAL and RAR. The following diagram represents an assessment made by AMI regarding the effectiveness, safety, and patient-friendliness for the various methods of treatment. It is based partly on the data published in the literature and partly on evaluations made by surgeons who have experience with the HAL and RAR methods. Up until now, the international gold standard for the surgical treatment of high-grade hemorrhoids was the conventional hemorrhoidectomy. The method's safety is described as normal to good. However, as the method is accompanied by quite high pain levels, the relatively low patient acceptance that results presents a considerable handicap. In addition, the wounds take quite some time to heal. This means that in many cases, a return to everyday life is not possible for several weeks. The method is rated particularly high because of the good cure rate for hemorrhoidal prolapse. However, the cure rates for those symptoms related to hemorrhoids such as bleeding, itching, and pain are less impressive. Outpatient procedures such as rubber band ligation, which is relatively safe and patient-friendly, display considerably lower cure rates for high-grade hemorrhoids and are therefore only of minor significance in the spectrum of hemorrhoid treatments. The main advantage of the stapling method is its patient-friendliness. However, reports of both intra- and post-operative complications can be found in the literature, some of which were also serious. Therefore, the level of safety is to be considered as lower for this procedure than for others. Results also show the stapling method to be inferior to the gold standard in terms of long-term effectiveness. The re-prolapse rates are significantly higher than for those for the conventional hemorrhoidectomy, while cure rates for the symptoms are lower. Where does the RAR method fit in? The method is minimally invasive and displays excellent results in terms of safety and patient-friendliness. Up until now, there have been no reports of serious complications occurring after HAL or RAR, although tens of thousands of patients have been treated with these methods. The very low level of pain allows patients to return to their normal routine very quickly, so the method can also be viewed favorably in economic terms. One criterion for the method's effectiveness is the re-prolapse rate. Here, the RAR method seems to achieve very good results. The publications available to date on the RAR procedure describe success rates in some cases equal to those with the conventional hemorrhoidectomy. A second criterion of no less importance in judging the effectiveness of a method is success in treating the symptoms. Current findings indicate that bleeding, itching, and pain are cured even more successfully with HAL and RAR techniques than with other methods. It is highly likely that this success is due to the decreased blood supply caused by the precise ligation of arteries. All in all, the RAR method shows very good results for all criteria: effectiveness, safety, and patient satisfaction. One further advantage of the HAL and RAR methods, which should not be underestimated, is the fact that the operation can be tailored to suit each individual patient. The result is that all grades of hemorrhoids can be treated effectively. In summary, HAL and RAR are minimally invasive procedures effective in both short and long term for all grades of hemorrhoids. Several studies containing many very interesting long-term results for HAL and RAR methods have been published recently. The range of literature available covers several thousands of patients. Most of the studies to date were carried out in Europe, where the methods established their firmest foothold. The present study confirms that the RAR procedure is a very effective technique for treatment of high-grade hemorrhoids. RAR offers a variety of advantages, including improved treatment of symptoms. The use of RAR will lower or eliminate invasive operations. It is a painless and minimally invasive procedure that offers an excellent alternative to a hemorrhoidectomy. DG HAL with the selective application of RAR is a safe and effective technique for advanced grade hemorrhoids. HAL is superior to sclerotherapy in stage 1 and more effective than rubber band ligation in stage 2, regarding the success rate as well as the relapse rate. Given the low complication rates and therefore the low risk, it may well be reasonable to offer DG HAL as a first-line treatment. In conclusion, both the closed scissors hemorrhoidectomy and the DG HAL procedure proved effective in treating hemorrhoids in both the short and the long term. AMI, Agency for Medical Innovations, is an Austrian manufacturer of medical technology based near the shores of Lake Constance, within easy reach of both Germany and Switzerland. For the last 10 years, we've been developing, producing, and distributing our medical products from this location. Our strong sense of corporate social responsibility is reflected in investments such as the founding of a public daycare center within our headquarters in Feldkirch. One of the company's main strengths lies in the fact that we develop and manufacture products according to the highest European standards of quality, and do so as quickly as possible. We pride ourselves on reducing to a minimum the time that elapses between a product idea and its realization. This strength has allowed AMI to experience continual growth and to gain a firm foothold in the market as an established European manufacturer of medical products. Our activities are focused on the areas of minimally invasive surgery, coloproctology, bariatric surgery, and urogynecology. We develop products with that special something extra, and have set a trend on several occasions. Not just with HAL and RAR surgical techniques, but also in earlier years with particularly soft and thus patient-friendly gastric bands. Other products include laparoscopic instruments, infusion ports, hernia meshes, and an artificial anal sphincter system, just to mention a few. Despite their differing applications, they all have one thing in common. Based on innovative ideas and manufactured according to our high-quality standards, they enable doctors to take even better care of their patients.